So I'm just going to make a start and I'm going to introduce Dr. Praveen Kishore, who is a consultant neonatologist and a very close friend and colleague who I have trained with and worked with. So Praveen basically has trained all over the UK, but majorly in Brighton and Southampton. And Praveen has a very keen interest in neonatal education. He runs the simulation instructor course with me, as well as the neonatal difficult airway course with me. But he has completed a postgraduate qualification in neonatal education and currently works as a neonatal consultant in Brighton. Uh, his other special interest is pediatric cardiology, and that Praveen completed a spin while he was working in Southampton with me. So he's an extremely multi-talented individual, and he has a keen interest in point of care ultrasound. He has done and completed the last lung ultrasound course with us. So he is going to present today post-hemorrhagic ventricular dilatation, which is a follow-up from the talk that I had done on IVH last week. So without further delay, I will hand the floor over to Praveen and mute myself.
Thank you so much, Alok. Thanks for your very kind introduction. It's been a pleasure having worked with you in the past, and it's always good to come back to Improve Academy courses. Can everybody hear me clearly?
Yes.
Yes.
Brilliant, thank you.
Yes.
So I'm going to just check if my slides are moving and if you can see them. Can you see my slides move?
Yes.
Yes.
Brilliant. Okay, so we'll make a start. So today we're going to talk about post-hemorrhagic ventricular dilatation, largely on cranial ultrasound because that is the course that we are on, but also we'll talk a little bit about pathophysiology, how they look on ultrasounds, also what are the different measures that we use, how do we monitor it. And then it's a big topic, management of ventriculomegaly and post-hemorrhagic ventricular dilatation. We'll be talking in the coming week. That will be the next lecture. So intraventricular hemorrhage, as Alok probably has talked to you about previously, it is a major complication in preterm neonates, and it results in very poor neurological outcomes. If you have a post-hemorrhagic ventricular dilatation, there is a 3 to fold increase. So that's 300 to 400% increase in neurodevelopmental delay. And unfortunately, despite all the new technologies and a lot of changes in neonatal care, the rate of IVH stays quite similar, or all the more because we have more premature infants, 22 to 25 weekers, and there is an increased survival as well. Also, with newer technology, we have more ultrasound, more MRI, more CT. So there's a lot of new evidence on post-hemorrhagic ventricular dilatation, what to do about it. And it's not going to leave us anytime soon. So the best approach probably is to get used to get used to it and learn about it. There is a wide variation in diagnosis and management among neonatal units, and I will be quite curious and I would like to know from you guys how you deal with it and how you manage it. So the most common measurement, the Levine's ventricular index, was established in 1981, and we will talk about it. It still seems to be one of the commonest used ways to monitor and manage PHVD. So today, the learning outcomes that we have are that we'll try to define what is PHVD. We'll talk a little bit about incidence and magnitude of the problem, how big a problem it is in neonates. What is the etiology and pathophysiology? I think it's really important to understand what are the different mechanisms by which post-hemorrhagic ventricular dilatation occurs and how it can cause trouble in the future. We will seek some cranial ultrasound appearances. We'll talk about how to measure it, where to measure it. We'll try to talk about how to monitor, and I'm not going to talk too much in detail about clinical signs of hydrocephalus because I'm sure you're all pediatricians and neonatologists and you know about it. I'm going to concentrate on cranial ultrasound and imaging largely, and then management will be dealt with in our next lecture. So to start with, and to make it less, it's postprandial time in the UK. So to prevent people from getting sleepy, there are a few confusing terms. So there is something called ventricular asymmetry. Then you have post-hemorrhagic ventricular dilatation. You have ventriculomegaly, asymmetrical ventriculomegaly, colpocephaly. So there are quite a few terms, and I'm quite curious to, I'll show you some images, but I would also like to understand what your understanding is of what is ventriculomegaly and what is ventricular asymmetry. So let's see this image. So this is a 28-week preterm, 5 days of life, no previous IVH. I would like to invite you to have a look at the images and tell me what you can see and what you think the diagnosis might be here.
So feel free to have a look, take about 15-20 seconds, and then you can unmute yourself.
Can I read? Is it okay?
Yes, please.
Yeah. So in the first image A, which probably is the most anterior frontal view, where we can see the occipital, this optic glare of the frontal bone. Yeah. So in this image, we can see that there is the interhemisphere, this cella. We can see that normally in this view, the ventricles would be slit like the frontal horns of the little ventricle, but the size look little, as in they're dilated, and we can see the corpus callosum and the and compared to, if we go to the second image, there we can clearly see that the lateral ventricles are looking dilated, and the hyperechoic densities in the both the bilateral ventricles, which could be hemorrhage.
Yeah, thank you so much. Very well described. So image A here is, you can see the frontal horns of the lateral ventricles, which appear to be more generous, more, open and bigger than you would see usually. Because there was no IVH previously, it's very difficult to say whether it's secondary to a pulmonary, to a hemorrhagic bleed. So I would just call it ventriculomegaly. This is at the level of, if you see that the lateral ventricles are almost opening into the third ventricle. So if you see my mouse, you can see that it's almost at the level of foramen of Monro, where the third ventricle is almost opening up here. And then this image B is looking at the occipital horns, where you can see a bit of the choroid plexus. Difficult to 100% rule out whether there's any bleed, but sometimes the hyper echogenicity of choroid plexus could just be an appearance, and it can depend upon your settings. So if I'm told that there is no history of IVH, I would just say it seems to be a mild ventriculomegaly. The reason for which I'm not sure, there will have to be more investigation about what was the history and how things progress. So I'm going to look at some other images. So this one, so the first image, and that's on the left of the screen, is that of a baby who had a history of antenatal ventriculomegaly. And postnatally, after he was born, this ultrasound was performed. And you can see that there is a little bit of dilatation on the right side, but none on the left side. And a subsequent MRI was done, and you can see that there is dilatation of the ventricles on the right, but none on the left. When it was investigated, it was found to be an isolated ventriculomegaly because of some obstruction at the level of the aqueduct. So isolated ventriculomegaly, so on one side. And then on the next image, you can see this is an image of a 26-weeker preterm, 3 days of life. Anyone want to volunteer talking about this? Please you can have a good look. And
I think this is asymmetrical ventriculomegaly.
yeah, that's right. And thank you, Nashwa. That was well described. It is difficult to say whether it's definitely ventriculomegaly. They do appear a bit prominent. In a preterm 26-weeker, the sizes might be in the remit of in the zone of normal. And interestingly, if your baby is lying down just on one side, and you are not in midline and you try to scan, you can have a little bit of asymmetry, and that's just normal imaging asymmetry of the ventricles. So these are different, appearances that you have to correlate clinically with what's happening, what's the history of the baby, and take it from there. So isolated images are very, very difficult to interpret, as you have seen. So the definition of post-hemorrhagic ventricular dilatation is any ventricular dilatation caused secondary to intracranial hemorrhage in neonates. So you need to have that history. You need to have some previous scans showing some evidence of a degree of bleed. And then the degree and grading of this post-hemorrhagic ventricular dilatation, it's based on measurements of ventricles, which we will talk in great detail about. So the magnitude of problem, despite all the development in neonatal care and neonatal science over the last 10, 15 years, it is still quite high. So the incidence of IVH, as Alok has already discussed with you, it is very variable. There are lots of different reports, but largely to what I could see, it was ranging from some studies say 20 to 25%, others say 15 to 30%. So a broad range is 15 to 30%, which pretty much means that below 32 weeks, almost 1/3 or 1/4 of your babies will have some IVH. Now, which are the babies who are more at risk of developing PHVD? Grade 2, about 12%, so 1 in 10. However, as soon as you go to grade 3 IVH, it is up to 80%. And again, I know that differentiation of grade 3 and grade 4, I'm not going to touch that because Alok has already talked to you about it, but there is a papille classification, and almost 80% of babies who have had a grade 3 IVH, there is a risk of developing some degree of post-hemorrhagic ventricular dilatation. High-grade IVH incidence will increase up to 50% if the baby's weight is less than 750 grams. What's the need of intervention? Almost 25 to 50% babies who have developed post-hemorrhagic ventricular dilatation with grade 3 IVH, they will need some kind of intervention. And if you've had a post-hemorrhagic parenchymal infarction, it will almost half of those neonates, they will develop PHVD. So clearly the picture is IVH is common in preterm babies, 1/3 to 1/4. Of them, grade 3 and grade 4, high incidence of PHVD. And if you have PHVD, almost 50% of the babies with grade 3 or grade 4 will need some kind of surgical or non-surgical intervention. So I'm going to now talk to you about the pathophysiology, going back to basic sciences and going to talk a little bit about how the CSF is produced, how it flows. When I did my undergraduate medicine in India, this used to be a common question in physiology, and I'm going to refresh that and if there are any volunteers, I would be very happy to learn about where is the CSF produced from, and then how does it drain? Any volunteers? Don't worry, I'll start talking
Yes.
to you.
Um,
Please go on,
yes,
Mohammed.
please. Yes. So it will start with the choroid plexus.
Good.
Then we'll go to lateral ventricle, then third ventricle, then Monroe.
Yeah.
More lateral ventricle, Monroe, then third ventricle, then aqueduct aqueduct of Sylvis.
Yeah.
Then fourth ventricle, then
Yeah.
Magenta and Luschka, and then to around the brain to the subarachnoid space to subarachnoid villi.
Brilliant. That's amazing. You must have scored very high in the physiology papers because I have to go back to the images again and again to remember the names. So as Mohammed correctly pointed out, so this is an image. So what happens is that the choroid plexus, here it is in the wall of the ventricles that produces the CSF that goes through the foramen of Monroe into the third ventricle to fourth through aqueduct of Sylvius, from the fourth ventricle into the surrounding spaces, into the surrounding sinuses via the foramen of Magendie and Luschka, and thereafter it is reabsorbed in via the arachnoid villi into the venous sinuses. And actually, what post-hemorrhagic ventricular dilatation does, we have some theories as to why does the hemorrhagic dilatation, post-hemorrhagic dilatation happens. So we'll talk about it. So that's the lateral ventricle on a cross-sectional image. Here, you can see that, which you will see on your sagittal and parasagittal images on cranial ultrasound. And then you can see if there is a third ventricle which is dilated, you will be able to see that on your parasagittal images. And then if the fourth ventricle starts becoming dilated, I'll show you some images, then that will, and it could be obstruction proximal to it caused by blood and its products that can also cause post-hemorrhagic ventricular dilatation. So the theories are that acute obstructive ventricular dilatation from blockage of the drainage of CSF. And what happens is that the blood clots will go into the cerebral aqueduct or the fourth ventricle outlet. That's the foramen of Luschka and Magendie. And the problem is that if this drainage gets blocked, then there is raised intracranial pressure. And that raised intracranial pressure presses on the white matter, causes periventricular edema, persistent dilatation of the ventricle, and that mechanical compression of white and gray matter causes everlasting neuronal damage. There are some animal studies. So they have found that if we manage to drain this CSF, so what they did was they induced post-hemorrhagic hydrocephalus in these rats. And when they did early drainage of CSF, they found that there was better myelination, there was compensatory myelination before axonal injury, and better cerebral perfusion and oxidative metabolism in these rats. So these are some of the theories. We will also look at what are the different sites where things can get blocked and cause hydrocephalus. Now, till very recently, there used to be this theory of arachnoid villi, and I was a very strong believer in it, that what happens is that the blood particles, the hemosiderin and things, they come and get deposited near the arachnoid villi and the arachnoid granulation, and these microthrombi is what causes hydrocephalus. Does that make sense? Many believers in that?
Yes, it could be in case of communicating hydrocephalus.
Yeah, but when we talked of post-hemorrhagic ventricular dilatation, it's very interesting that arachnoid granulations are not present in preterm infants. Granulations are only seen at term gestation. So the current evidence suggests that it is unlikely to be true. So when we talked about the other places of probable blockage, so we talked about, so there is intraventricular obstruction. So It could be blockage at this level. These are the lateral horns. So what it causes is, if there is obstruction here, they start to become dilated. So that's the ex vacuo dilatation. Then there can be disturbed resorption. That's the theory that we are talking about. And arachnoid granulations, that theory does not seem to have enough evidence, at least in preterm infants. There is also some evidence that ependymal and subependymal damage causes because of the hemorrhage, that causes destruction of the ependymal cilia. That affects CSF flow as well as production. And as a result, all of these things, combine and cause ventricular inflammation, dilatation, the pro-inflammatory markers, TGF-1 alpha, TGF-beta-1, TGF-beta-2, vascular endothelial growth factor, all of these together cause ventricular inflammation and dilatation. So lots of pathophysiology, and I don't think they're all essential to know, but this diagram is quite important. When you look at this diagram, you just need to remember, where do things drain from? Because occasionally you may not have the typical dilatation of the lateral ventricles. So I'm going to show you an image now. So this is a 25-week gestational age baby in whom there was an IVH. There was a little bit of lateral ventricular dilatation. However, it was the fourth ventricle that was isolated because the clot was sat here. This is where they had the fourth ventricle was the most affected with the dilatation, so much that they had to put a Rickham reservoir, and you can see a big cystic fourth ventricle here in the images. You can see this image, which is very clear, and it's compressing on the brainstem and on the cerebellum. It's a huge cystic ventriculomegaly isolated ventriculomegaly of the fourth ventricle. So we have to remember the drainage, because occasionally the blood can cause just obstruction of the aqueduct or just obstruction of things lower down and cause isolated ventriculomegaly. So now I'm going to talk about the measurements. And this is probably one of the most important bits, because now you know that a hemorrhage has happened. There is ventricular dilatation. But then when do I act? What's the point at which we should be worried about? So what are you using currently in your units? Anyone wanted to volunteer? What are you using on your cranial ultrasounds currently? What measurements are you using currently to tell you, okay, this is what we need to do, or this is significant post-hemorrhagic ventricular dilatation?
Ventricular index, anterior
Yes.
horn,
Yeah.
anterior horn index, anterior horn, and occipitothalamic diameter.
Oh, brilliant. That's really useful to know. So
The third ventricle also.
third ventricle also. Yes, absolutely. If you have a third ventricular dilatation, that also makes it very important. That's quite important to be measured as well. So thanks, Nashwa. I'm going to talk about the different measurements, but clearly ventricular index has been here from 1981, so almost as old as a few of us. And that is still quite important, and still lots of units in the UK and Europe go by ventricular indices to measure or monitor post-hemorrhagic ventricular dilatation. So on your cranial ultrasound, you need to be at the level of the foramen of Monro. So basically, your lateral ventricles, the frontal horns of the lateral ventricles should start opening. And if it is a pronounced post-hemorrhagic ventricular dilatation, you'll almost see that these openings will open symmetrically, and I'll show you some images, into the third ventricle here. So that is the point that you want to be in. And at that point, you want to measure from the midline. So the greatest distance between the frontal horns at the level of foramen of Monro. So the maximum width is what you want to measure. What is the maximum width from the midline? That is what you would like to measure. Now, this is more sensitive than head circumference measurement. It takes away that inter-observer or even intra-observer variation. And that is why it is probably one of the most commonly used measures to predict timing of intervention, to tell you, okay, now I think this is significant. We need to do something about it. Oh, this looks really bad. The VIs are above this point in the chart, and they will probably predict poor neurodevelopmental outcome. So on this image, you can see that a shunt has been introduced. And that's what I was saying, that once you have a big ventricle, you can almost see it opening into the third ventricle. And that's almost the level of the foramen of Monro. However, so you need to measure it on both the sides from the same point, ensure that you have measured, the biggest width on both the sides. The only problem here is that the VIs increase only later. So a mild dilatation is many a times missed. It increases only in severe hydrocephalus. Also, originally the Levine study, you can clearly see that it was done in 81 or quite a long time back. And at that point, only babies who were older than 26 or 27 weeks were included. Clearly, our populations are different. So following that chart is quite difficult. So these are a couple of Levine's charts, and I'm going to just try to minimize this. So this is one of the Levine's chart. This is the most commonly used one. I think if you work in UK or NHS, most of you would have seen this. So this line, so on the x-axis, you have gestation in weeks. On the y-axis, you have ventricular indices, like we measured in millimeters, and you plot it. And then this line shows the 97th centile. This line shows the 97th centile plus 4 millimeters. So anything beyond this 97th percentile and 4 millimeters is where historically neurosurgeons have been interested, historically where we have thought, okay, this now needs an intervention. Prior to that, in this area, or if it is below this area, we wouldn't be too bothered. If it was in this area, we would say, okay, fine, maybe we'll just continue to monitor. Sorry, it just keeps running away. This is the another depiction of Levine's chart. You can just see that we have more. So I think it's a modification by Brower et al. And I think it came in 2012 when they got some more data to show what happens in 24, 25 weekers, and they extrapolated it up to 42, 43 weeks. And they have the same thing. The lower line is 97th centile plus 2 standard deviations, and anything above the 97th plus 4 mm is the intervention area. Before that, it's just the surveillance or close monitoring zone. So across majority of centers in UK and Europe, still it is used all the time. However, as we've just talked, one of its limitations is it does not show mild PHVD. Also, it changes with gestation age. So as you can see, even if the baby did not have a massive post-hemorrhagic ventricular dilatation, it would still increase. The ventricular indices would still increase with growth of the child. So with gestation, it does not remain static. So that is a problem. Now, due to this, the second important calculation came in, and this was the anterior horn width. So this is a post-hemorrhagic ventricular dilatation. You can see the prominent lateral horns. You can see how they are draining into the third ventricle. And what is the anterior horn width? So diagonal width of the anterior horn in the coronal imaging at the level of foramen of Monro. And it is the widest distance between the medial wall and the floor of the lateral ventricle. So the widest distance that you can measure, that is the anterior horn width. Some more images to show the difference. So what is B here?
Okay.
Sorry.
Ventricular index.
Yes. So B is ventricular index and A.
A, anterior horn width.
Exactly. So A is the anterior horn width. And you can see that the early sign of increased intracranial pressure is now it's well identified that it's not just the width of the ventricles, but a rounding of the anterior horn. So it starts becoming rounded and tense. These bags of CSF, they start swelling. They start becoming more and more circular. And that is one of the earlier signs of increased intracranial pressure. So it is more sensitive than VIs to find out early ventricular enlargement. And the other good thing is that it does not change with gestational age. So I'll show you the graph. It does not change like the VIs for 28, 29, 30, 40 weeks. It will still stay. So you can see these two charts. The VIs are going up, left VI going up. However, anterior horn width stays pretty much the same. And this is all in terms of post-menstrual age, so corrected gestational age. Here you can see on image D, you can see number 1 is the ventricular index. Number 2 is the anterior horn width. Sometimes if we can see the third ventricle, we will measure that as well. It can help. In addition to the other measurements, it might be able to help get an idea of the neurosurgeons may be interested in knowing, okay, what's the third ventricle looking like? How big is it? What's the fourth ventricle looking like? So Davies et al., they've made the first anterior horn width monitoring chart, and this was, again, quite a long time back in 2000s, but I have to confess that it has not been used till recently. I think only now there is a bigger realization that there have to be more than one measurements, that VIs alone, ventricular index alone, is not enough. Am I going okay with the pace? Is everyone happy? Any questions? Anyone wants a quick break?
No, Praveen, good pace. Go for it. Carry on.
Brilliant. Thank you.
Yeah, it's fine. Yeah.
Cheers. So you can see that this is the anterior horn width chart. There is no change because of gestation. It remains very similar. And that's why there are clear numbers even for that. Okay, this should be the thing for term. This is how many millimeters it should remain for preterm. And it stays pretty static. So severe dilatation is said to be about 10 millimeters and above. If your anterior horn width is 10 millimeters and above, you will probably say, okay, it seems to be quite severely dilated. Remember that not just one measurement is never enough, so we will be talking about some more. So now we come to the third measurement, and that's the thalamo-occipital distance or occipitothalamo distance. We call it TOD. So where do we measure it? So it is being measured. We have to, of course, measure on both the sides. In the coronal section, you had the advantage of being able to measure in the same section. So you could have measured it on the right and left in the same section. But that is a minor problem that I find here, because there can be a little bit of variation in where you are measuring it. But you have to remember the guidelines, or the suggestion where we should measure it. So it says distance between the outermost part of thalamus at its junction with the choroid plexus. So this is the thalamus in the parasagittal section, and this is its junction with the choroid plexus. And then the outermost part of the occipital horn of the lateral ventricle. So this is the occipital horn of the lateral ventricle. This is the parasagittal image. And you measure it from here to here. I have to confess that although there are some guidelines and some people who are measuring it, I feel because there is a little bit of variation in who is measuring it and where, it's probably not come into picture as much. I know that some units do use it as a part of their standard sort of assessment of hydrocephalus or post-hemorrhagic ventricular dilation. It is interesting to see, if you see that choroid plexus, you can still see a small clot here. attached to the choroid plexus. And you can almost see that there's a bit of dilatation appearing here. So I think this is an image of a hydrocephalus that's still developing. So TOD does vary with gestational age, and measurement can be challenging. However, its evaluation does give us more information. It gives us a little bit of more, it adds more value. Why do we measure TOD? It is the earliest and fastest, it shows the earliest and fastest increase in size in PHVD. So if you are worried that this child had a grade 4 IVH and most likely a post-hemorrhagic ventricular infarction, these are the babies who are at the maximum risk. And uh, if you want to sell your case to the neurosurgeons to intervene, like we have to do in UK, you will have to show them that in 5 days, this is how fast my TOD has increased. Because the VIs, although they are easy to measure, they may not have gone up by that much. So they will only be convinced if you have all of these measurements. So that's the right TOD, left TOD, and this is from the Harvard University of Medicine. So LDIB et al. In 2020 they made these charts, and these charts are based on the gestational age, and you can see that there's a little bit of variation. Not as much as the ventricular indices, but yes, nevertheless there is a little bit of change. Other measures, like some of you previously already said, that the third ventricle is a good one to measure. If there is an isolated fourth ventricle, which looks quite significant, you need to measure that, because there are Z scores and there are ways to sort of find out that, okay, is this quite significant? Resistive index. Now, I do not know, have you gone through resistive indices already, Alok, in lectures?
Yes, we have. We've covered it in HIE, so the folks are very familiar with it, yeah, and the values
Fine.
and how to measure it,
Yeah.
yeah.
Thank you. So we know that resistive index is sort of a ratio of what is the peak systolic velocity, what's the end diastolic velocity. And if your resistive index, the higher your resistive index, it means that most likely your diastolic flow is about to be close to zero or even, reversed. And that suggests that the cerebral perfusion is poor. So the higher the dilatation, the more the increased intracranial pressure, the resistive index will go up further, and that will suggest that there is poor cerebral perfusion. RIs of 0.85 and more do suggest that there is a need for ventricular drainage. It could be through a device, it could be through a lumbar puncture. So I'll show you a very interesting image. So the upper image here, so the first image, you can see that this is a ventricular index. You can see that the systolic velocities are high, but the diastolic velocities are almost close to being absent. So that ratio would be like 0.85 or 0.9. And what happened later, they did a lumbar puncture, took 10 mils per kilo of CSF out, and you can see how the diastolic pressure has gone up. So the diastolic velocities have gone up, and that means the cerebral perfusion pressure is restored and it gets better. So changes in RI can be seen if a significant amount of LP drainage of CSF has been done. There are some other measures which have been derived. You can do it on a cranial ultrasound, but largely from MRI and CT scans, and they are ratios because, as you can see, every baby's biparietal diameter, which is from this end to this end in coronal sections, would be different. So a ratio, so for the same baby, a frontal to biparietal diameter ratio or a frontal to temporal horn ratio, that helps to sort of monitor things. So there's something called Evans ratio where you have frontal to biparietal diameter ratio. You can measure a temporal horn ratio or an occipital horn ratio, and they are measured all these places. I have to confess, I have never done them. If you have reached this point, you have to just ask your neurosurgeons, guys, Are you going to put a shunt here, or what do you suggest? What do you want us to do? So I'm almost coming to the end of our talk today. And I don't know what is your usual practice. I think it varies a lot depending upon where you are, what is your infrastructure in terms of what kind of radiological services you have available. Can you get a cranial ultrasound done? Do you have one on your unit? Is a CT easier? Is a MRI easier? Do you have pediatric radiologists who will happily give you a MRI date? So, what is your local practice, guys? I'm quite keen and interested to know that if you have a child who is developing post-hemorrhagic ventricular dilatation, what would be your usual practice? When would you contact the neurosurgeons, and how would you monitor them? Would it be head circumference, head scans, or would it be MRIs? Any volunteers?
Head scan and head scan, cranial ultrasound showing very high ventricular index, where we would seek neurosurgeon's advice.
Okay.
And meanwhile, if neurosurgeon is not convinced
Yeah.
to accept for drainage, then we would go ahead with MRI to support and then go back again to the neurosurgeon.
Brilliant. No, thanks, Kunal. That's really useful to know because clearly, in where I work, our regional center is King's College Hospitals in London, and I think most of the times they want us to organize an MRI. They believe us. They can see that the ventricular indices and the anterior horn width and resistive indices are going up. But I think it just helps them to decide, okay, this is the time for intervention. I'm not sure what else they are looking for, but it helps them calculate that this is the shunt that we'll need to put, or do we need to just put an extra ventricular drainage? So there are some studies, there's a lot of literature actually to say, how do you predict which is better, an ultrasound or an MRI? Which is better to predict the development of PHVD, and which has got more positive predictive value? So I'm just showing you a couple of papers here. One of them, I think, is from Amsterdam, and they performed serial cranial ultrasonography and early MRIs. And they compared it, and they said that cranial ultrasound is quite good to detect acute IVHs, strokes, cerebral synovenous thrombosis, but they did not find it to be very useful in detecting cerebellar hemorrhages. So that was their feeling. And there's another study which says, and actually one of the, this is from Karolinska in Sweden, but one of the consultants, I think she used to work in Southampton as well, Alok might know. So they have here compared the predictive values of cranial ultrasound versus MRI, and they have scores to say which of these babies will end up developing cerebral palsy or severe cognitive delay. And their study showed that predictive values for severe cognitive delay were equal, whether you used cranial ultrasound or MRI. So it's very interesting. I feel that as far as neurosurgeons are concerned, they do want MRIs, but I think that's there is different practice. And in the next lecture, we will be talking about MDT approach to how to deal with progressive periventricular post-hemorrhagic ventricular dilatation. So thank you. This was as far as I got to today, because I thought I didn't want to overload. Once we start with the approach to ventriculomegaly or approach to hydrocephalus, I think it is another huge topic, which probably is best covered in the coming lecture. I think what we will be covering there is medical management, some non-surgical CSF drainage approaches, surgical devices, but we will also be talking about the drift study, the Elvis trial. So a lot of different things have been used, a lot of different techniques and strategies have been used to try to reduce the neurodevelopmental damage that post-hemorrhagic ventricular dilatation and IVHS can cause. So many thanks, and I'm happy to take questions.
So, Praveen, I have the first question.
Yeah.
So, one of the challenges that we face, in particular, with kind of following up ventricular dilatation is when you have a co-located, say, grade 4 IVH
Mm-hmm.
and measuring VIs, because
Mm-hmm.
often the IVH basically occupies the lateral margin.
Yeah.
And
Yeah.
again, you have ventricular dilatation, and IVH, grade 4 will take its time.
Yeah.
So, how do you approach measurement of VIs in that situation?
And I think very interesting question. And I can almost see that I have been in that boat, so many times where I'm like the outer margin of the VI. I'm just going back to some of the images just to show what we are talking about. So say if we go to, there was one in which we had, yeah, say this one. So this is a lateral ventricle. If I had to calculate the ventricular dilatation, I would probably still be able to calculate the maximum distance. But sometimes in grade 4, all of it is full of blood. There is some periventricular involvement as well. And I think really my answer is you cannot just go with VIs there. You will probably have to take other measurements as well. So you will have to take an anterior horn width if that's possible. You will have to, uh, the parasagittal images might be very useful here. So this might still be possible because your bleed will probably be here in this region. So you might still be able to measure the thalamo-occipital distance. And if you are measuring that and comparing that serially, you might be able to say, okay, it seems to be rising up quite fast. So I think it will have to be an approach of taking all the 3 or 4 numbers and following them up because VIs, I agree, Alok, it can be so tricky if that the place which seems to be the maximum distance, if you're trying to measure there and there is a lot of blood there, where do you measure? I don't have the answer to that.
No, I think you've answered. I think
Mhm.
that's the approach that I would take in that measuring the anterior horn width and the thalamo-occipital diameters
Yeah,
might just give us a little bit more information to be able to convince people that this might be a baby for intervention when we clinically correlate looking at things.
yeah,
The
yeah.
other challenge, obviously, that comes in with we often see VIs increasing, but a very late increase in head circumference and
Hmm.
thinning of the cortical mantle. And that is an area that is very controversial at the moment, in that sometimes we feel compelled that there's ischemia in the periventricular areas. This is not going to be a good outcome. Should this baby have some kind of an intervention? Yet the neurosurgeons tend to want to wait until head circumference rises. And
Yeah.
or, sometimes I get interesting questions is, do you have signs of raised intracranial pressure? Well, my answer is, do we want to wait till we get those signs?
Yeah, I agree with you. I think there is no clever answers there, unfortunately, because it depends on what neurosurgeon you have. Or luckily for us, I think our local King's College means I know that the surgical thresholds are high. A, because they want the child to be larger, to be able to put a shunt or a device. B, they want them to be hemodynamically stable. They
Yep.
want to put a shunt or a device only if they feel that the baby's prognosis is going to be good. So if it is, large grade 4s on both the sides, they are like, oh, you transfer this child for a shunt, the baby might not make it. What's the point? So I can understand that they try to push back a little bit. But that said, if you have enough evidence, if you have shown them that you see this is the cortex, or you can probably show them that the BPD, the biparietal diameter ratio, that it is going worse.
Yep.
And sometimes we just executively we just say let's do an MRI and send
Yep.
it to them. It
Yep.
will show us some more. um, yeah, clinical features, I agree that head circumferences, I might measure something today, someone else tomorrow can come and say it is static.
Hmm.
Third day someone else will come and say, oh, it's more by 3 centimeters. So it becomes very tricky.
Fair point. So,
Yeah.
any questions? I can see Nashwa, you're unmuted. Do you have a question?
Yeah, I want to ask, yeah, if I have a baby, preterm baby, and he has IVH already, at what time I should follow up him? Yani, I did the first scan within the first week, and already I have IVH grade 3 or 4.
Mm-hmm.
And by the 7 days, I will do again the scan, and I found the ventricle is dilated.
Mm-hmm.
So at that time, I took the measurement, and it is more than 97 plus 4, like you said, the anterior horn width. So at that time, I should do the LB, and I start my the chart to follow up the chart to do the LB 3 times. If it is not improved, I will go for reservoir or my reservoir or what. I want to know the sequence and what should I do? Early intervention or late intervention is better.
So, thanks, Nashwa. Very good question. And I think some of it we will be talking about in the next lecture because early intervention versus there is some evidence to suggest that early intervention is better with lumbar punctures and things. Equally, no investigation is going to be, no intervention is going to be free of problems. Doing LPs repeatedly, the amount of LP, the amount of CSF that they want you to drain sometimes is not humanly possible. They ask you to take out 10 to 20 mils. You barely get 5 drops of CSF after 5 people having tried. So you have to balance, your risks and benefits. So
Sorry
question,
for this
how,
point. Sorry for this point. Should I do ventricular tapping
um,
at that point
we,
because to overcome this problem in the LB?
hmm,
Can I answer
yes,
the
please,
approach
go on,
that
Alok.
because it's really interesting. So when I was in the UK, we'd almost start with lumbar punctures always because we were very worried about the destructive nature of ventricular taps. But interestingly, practicing in the Corniche, we've realized that smaller babies getting into the CSF space and getting an adequate amount of CSF to then decompress is really difficult. And maybe with the first lumbar puncture, second, you might, but actually, if you have to do serial lumbar punctures, it gets more difficult with time. So we've actually we just do ventricular taps, and whilst I was surprised about it, the one thing that it definitely does is get an adequate amount of CSF out.
Yeah.
What's your approach, Praveen?
Very interesting because I have seen approaches change a little bit. So when I was in India, we would not hesitate at all in doing a ventricular tap. I think the invasiveness of a ventricular tap is what puts off a lot of people in the UK and probably in other European countries as well. I have seen, I worked at Bristol, which was the place where drift trial was started. And there we used to put reservoirs quite early on.
Yeah,
So we would either have a extra ventricular drain that you could tap, or you would put a omaya and you could tap the omaya easily. It is very periventricular. So right now where I'm working, we do not have a neurosurgical center. So if we have to send someone, most of the times they want us to be doing CSF taps, which is very difficult, like you said. But equally, I get a lot of reservation from my colleagues if I ask them to be doing ventricular
yeah,
taps
yeah,
because it's just something that they have not done very frequently.
yeah.
I do agree that it will probably help. It will be easier to do. It will get off more CSF. So probably less traumatic for the baby, really, if speaking. Uh,
So interestingly, with the next talk, Praveen will be presenting the management, and then just I would like to mentally prepare you that the session will be slightly long. So please do have your breakfast, dinner, tea, and a good, nice cup of coffee with you. Because whilst we'll be talking about management, we will be presenting cases to give you the kind of differences in approach. And at the moment, there is very little evidence from any kind of randomized control trial that actually says that one particular approach is better than the other, and that is the real challenge that we really need more research in this area.
yeah.
Any other questions?
I just
Yep,
wanted to answer the one
yep,
of the other bits with that Nashwa raised,
yep,
saying that I have this baby. So we have to remember a grade 4 post-hemorrhagic ventricular infarction is likely to cause a faster increase in PHVD. So that one, if they say that most IVHs have happened by day 5, day 3 to day 5. By that time, it has happened most of the times. So if you have a grade 4, you would probably want to follow them up regularly. We used to do alternate days head circumferences and maybe twice a week at least for
That's good.
the VIs. So I think that should be enough. And usually, if it is a smaller bleed, ventricular dilatation won't be apparent till at least a couple of weeks. So only by day 14, 15, you'll start to see some increase or dilatation in the VIs. Yeah.
We'll be covering screening as well, both for IVH, post-ventricular hemorrhagic dilatation, and PVL, which Dr. Rajesh will cover. So hopefully we'll get some structure from that as well. Any other questions? Fantastic. I'm going to take this opportunity to thank Praveen for what has been a very thought-provoking talk. Uh, More next Thursday. So we've got a little bit of a gap for you guys to catch up, and I'll be sharing some of the articles. Uh, Again, thank you everyone for your patience, and thank you, Praveen. We're really grateful for what has been a lovely talk today.
Thank you so much, Alok. Thanks everyone for listening to me. And yeah, see you soon.